Hello, and welcome to Reede Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Reede Scholars. I am super excited to have with us Dr. Aisha Rahim, who is an internal medicine physician by training and currently serves as medical director at the John Hopkins Health Plans and is a member of several boards, which we will get to in the course of this conversation. She's doing a lot of things at a lot of places, and I really want to spend a little bit of time thinking about how to do this health equity in context of artificial intelligence and a few other things. So, welcome. How are you today?
Thank you. Thank you, Mary, for having me here today. I'm really excited and happy and doing great. Just a great morning. Just a little bit of snow here in Maryland, but otherwise doing great. Thanks.
Yes, it is officially winter with the rain slash snow slash frost or
I
whatever
know.
out there. Well, tell us a little bit. I usually like to start with giving a little bit of insight into your journey into health equity. So, share with us a little bit about how you initially got interested in the work and a little bit of background of your career up until this point.
That's a great question, Mary. As a physician, and I'm also hold another position, which is a mother of three children. I had two of my pregnancies were really complicated, and I'm not sure if I ever talked about this openly before, but I suffered from different, complications during pregnancy because of hyperemesis gravidae. I was admitted to the hospital, and being physician, every time I got admitted, and also working in the hospital where I was admitted, um, I noticed so many gaps and issues, even being physician, being able to advocate for myself. Um, every time I spoke up and I was, I had experiences which were I should not have, despite, the fact whether I was physician or not. And I always thought that if I am physician and can advocate for myself and still not be able to get the kind of help and health that I need, or the support that I need, what would be happening to other members of society, who are diverse like me, who don't have who are have different color, and not able to advocate as I am able to advocate. And so that sort of started me thinking during that journey of my life, where I was a hospitalist, but not really. It really ingrained in thinking about health inequities at that point. I used to see patients getting discharged to homeless shelters, people of color being labeled at certain names, but not really being able to really think about it until I, really joined Johns Hopkins Health Plans and started thinking about taking a population health perspective and looking at it from that bigger angle and bigger picture. And then also thinking deeper into how can we help our members in different, different diverse group of members. And I got involved in a health equity initiative, and that eventually translated to my work into national NCQA accreditation, where we are trying to achieve the health equity accreditation for our organization, and sort of opened my mind into the disparities that exist in our healthcare systems, and led me to explore this space a lot more deeper. And then I had the opportunity to attend your course a year ago, which also sort of opened my mind into what is and what approach should we take, and how should we benchmark health equity. And so yeah, so there's a lot more work that needs to be done. A lot, I would say, in terms of figuring out what are the key metrics we measure and all that stuff, and then our government's push to promote health equity in different spaces. I think that has all led to this whole ecosystem where we are now focusing on health equity as an organization and also in our communities in general.
Absolutely. And I'll take a second to do a little bit of definitions for our non-medical listeners. So you mentioned something called hyperemesis gravidarum, which is severe nausea and vomiting in pregnancy. And what we mean by that is severe enough that you need to be hospitalized, right? So you can't have anything to eat or drink, nothing staying down, you're dehydrated, oftentimes losing weight. So it is a significant medical problem, often requires multiple trips to the hospital, different rounds of medication, and so it can be quite disruptive, but it is also can be dangerous to the pregnancy as well if it's not treated. So thank you for sharing that, and I think that's something that we don't talk about as often. Like we often talk about morning sickness, right? But that's not debilitating. Hyperemesis gravidarum is really going to interrupt your day to day. The other thing you mentioned was being a hospitalist, which I think is a good thing to talk about. So oftentimes, but not always, right? You're an internal medicine physician and you work only in the hospital. So we think a lot about physicians who work in the hospital and in the office or clinic or both. Hospitalists, and in the cases of OBGYNs, laborists are dedicated to hospital work. So it gives a little bit of a different perspective, right? And a lot more, and because the shifts you work, because generally you work multiple shifts in a row, so you really
Exactly.
get intimately involved with the patients who are there at that point. And to your point, discharge management, case management, and figuring out where people are going is more of an intimate part of your role than I think it has been in the past for that type of position. And then kind of lastly, you talked about population health, which is not necessarily new, but how we've talked about it in academic spaces has evolved, right, over the past, I would say, decade.
Exactly.
Yeah. And so thinking about how health affects whole communities. And so a lot of times, we look at statistics and what they look like for certain populations, but also looking at it on a larger community level and defining community in different ways, whether that is a neighborhood, if it's a state, if it's a country. But and really even being able to get to the micro level with some of our geo mapping, right? And really being able to drill down to zip codes, and that I think has influenced the term place matters, right? And even though when people live a mile apart, their health outcomes can be drastically different because place does matter, and as it relates to health equity and health outcomes. So with that, now and thinking about health plans and how you started your health equity journey as an individual and having something happen to you, but then being able to see it from a larger level through the lens of an organization. Um, can you talk a little bit, just kind of broadly, of how health plans can be instrumental, if you will, or influential in the health equity conversation? Because you mentioned it's kind of part of the overall fabric, but how do you um, operationalize it, if you will?
Yeah, that's a great question. Health plans are a very integral part of our whole health ecosystem. When you're a physician working as a hospitalist, you sort of don't understand that, and you don't your medical school curriculum is not um, enshrined or built in a way to understand that ecosystem that well. And so once you're sort of on this side of the aisle and trying to understand how things work on this side of aisle, health plans can play a pivotal role in, not establishing standards of health equity, but also how to improve it and how to go about it. So, you know, health plans could have members, and in our particular instance, we have members in different segments of the society. It could be Medicaid members, which have a different demographic. We have, members from military family members. We have employer health plan, and we have a senior members Medicare plan, and then we have some dual eligible plans. So we have different segments of society that we are looking from at a different from a different standpoint. We are looking at claims data. We are looking at how many members are African American, Latino members. We are looking at what are the outcomes, like how many members with diabetes end up having amputations, how many are ending up having chronic kidney disease, and how many are having repeated admissions to the hospital and not being able to fill your medication. We can see from a plan standpoint, we can see all that. We can also see what could be the barriers to from what could the barriers they be facing in terms of getting their medication, whether they're STUH, social determinants of health, which are the factors in our society environment which affect members or patients' ability to achieve the full capacity of the health that they're supposed to achieve. So we can see all that from a plan standpoint and we can address it. However, the issue here is how much the plan decides to address it, you know. There are plans that can take a full-on approach, and they have addressed even the homelessness situation as well. There are plans that have, they're focused on digital health literacy and digital health divide, and they could offer, internet services as part of their coverage or benefits. There are plans that have different sort of health benefits where they waive off copay for certain medication, let's say statin medication, to improve some certain measures. So plants do have the capacity, the power, and the I would say the finances to address a lot of it. And it just really depends upon what their mission is. If it's a plan that is just driven by no margin, no mission, which we have heard a lot, then it's a different sort of a mission. Where plans that are member centric and also focused on health equity, health equity metrics, then they make different sort of investments and different sort of community relationship to achieve those intervention. Now, the good thing is that with the NCQ accreditation, a lot of the health plans are now required to attain that accreditation, and part of that accreditation is not only to have all the data mapping of the population, whether SOGI data, race, ethnicity data, but also you have to have a disparity evaluation. And then the next step would be to work on the disparity. So when you work on the disparity, it means you're going to invest in those areas. Let's say whether it's prevention of amputation or reduction of chronic kidney disease so that member doesn't end up in dialysis. And this is specific for let's say diverse group of individuals, or let's say we focus on African American individuals, so that we can improve the outcome in that particular individual as compared to the other segments of the population. So I think that will, once it's required by the state and the government, then we're going to be able to see a little bit more push for the health plans to achieve that. And then once it is achieved, then more push in reducing the disparities. So yeah, that's in the nutshell.
Yeah, thank you for that. I think a few things there. One, just thinking about health plans in general, I think as an everyday individual, you have your insurance, you go to your, physician office or nurse practitioner's office or midwife office, wherever you're going. You give them your card, and that's kind of the end of how you think about insurance coverage. But health plans are very complicated, and I'm learning a lot about them. Having the multiple layers of different types of coverage when we think about Medicaid, even when you just think about Medicaid and Medicare, right? So Medicaid, it covers 50% of births. So that, to your point, the demographics of that population and the needs are going to be slightly different than our Medicare population, which generally speaking is 65 plus, right? That's our retirement age individuals. And then you've added in the military, which has, again, a different set of challenges around access and even disease processes, because they're going to be exposed to different things in their travel than an everyday American would be, if you will. And then you also added in our self-funded accounts. And so for most of the population, still, we get our insurance through our work. And that can bring in a whole range of population, right, across the company. And so trying to figure out how to design interventions that work for as many people as possible across the plan. I know it's daunting, but also it's a great opportunity, to your next point about, you've got the data, right? You have access into the data. So collecting the right data at the right time from all the members, so that you can then use that to be helpful to the population at large, is great. And then the last thing you touched on, which I think will take us to the next part of the conversation, is around chronic disease. And we know the population is aging. We just mentioned like the Medicare population, and chronic diseases are becoming more prevalent, and therefore the consequences of chronic diseases are becoming more prevalent. So you work on a few a few other initiatives outside of your everyday work around technology and chronic diseases. So, do you want to? I promised the people that we're going to talk about your board work. So, do you want to talk about those other elements of your career as well?
Sure, yeah. Yeah, that's a very great picture that you, I mean, this is the sort of picture that our population demographic is undergoing nationally. There is an aging population, then there is declining Medicare reimbursement, more hospital admission for that population, declining reimbursement, slower. The plans are getting less reimbursement, and so they don't want their patient to be admitted to the hospital. They have lesser pool of money. What do they do with that? So that's a great picture. I spoke about that in one of my conferences at the Social Health Conference in Reuters in Chicago this last November, and there is just so many aspects of this that we can help and control. And one of the main key takeaway was that we need to focus on preventative health. Okay, we need to change our mindset as every day. We not when we have the full blown disease developed. Yes, we have to manage that, but how to prevent those diseases. And our shift from in our society has not changed from disease management to disease prevention. And that's when you look at our plan and how they're structured from state and CMS and what they pay for, you can clearly see that they are not the reimbursement for a lot of preventative services. So we'll leave it that there. Now diving into one my work with other organization. I'm a board member at American Diabetes Association, and one of the things that we work is advocacy for our members with diabetes and patients with diabetes, and to make a change in community, to do community programs, and whether it be faith-based centers, whether it be stepping out, or whether it be getting getting together with corporate leaders to make sure that they meet their corporate social responsibility, getting fundraising. And so as part of that, our focus is to reduce the disparities in the diabetes space. And with that work also coincides with my work as a medical director leading the diabetes clinical strategy for my organization, because sort of I can see what's happening within my organization and see what's happening outside the organization and bring that sometimes expertise from outside, and then be able to give a little bit more holistic approach to the care of diabetes that we provide for our members. So one of the things that we're working is reducing the access to diabetes medication, reducing all the barriers to the diabetes medication, and also the preventative services that we offer for diabetes. And statewide, Johns Hopkins and University of Maryland received a grant under BMDRP Regional Partnership, which is Baltimore Metropolitan Regional Diabetes Partnership. We received a grant so that we can promote DPP, which is a diabetes prevention program for our members with pre-diabetes. That's where the prevention aspect comes in. And then diabetes self-management training program, which is management of the diabetes itself. And both of these programs are proven to reduce the hemoglobin A1C and also improve the outcome. And the program itself is focused on communities that are marginalized and in specific zip codes. So that is very great aspect of program, because we work closely in Baltimore City and other those counties where we have lack of access, and try to see if we can get as much as member enrolled in these programs. Again, our step to push towards improving health, reducing health inequities. So that's something that I do with ADA. Now, I also, in line with health equity, I'm a part of a digital advisory board role. I'm a chair for the committee, and what I do is basically that committee is formed so that we can advise the Morehouse School of Medicine's faculty into designing the curriculum for the faculty members based on the grant that we received for National Telecommunication Association. So they gave us a grant, they gave Morehouse School of Medicine some grant, and then we are part of that advisory board to advise them to develop a curriculum for a very diverse group of providers, so that they are in the forefront of leading the change and also have the best technology so that they can take care of the patients that are also diverse. As we know, Morehouse School of Medicine's faculty and students are 80%, I would say, African American, and then the other diverse population. So that is really the goal, to give them the best the advice in terms of what are the best technologies, whether it's a chat GPT to help enable the clinicians, or VR or augmented reality to have them encounters with diverse group of patients, so that they can um, learn how to interact with different groups of patients and individuals. So yeah, so that is one aspect of my work that I do. And then the other part, digital advisory board roles that I have, is to teach organization regarding biases in artificial intelligence. Now, every organization is using artificial intelligence as either a part of their population health management, or whether it's a digital health startup and techs. And so what they are encountering is that a lot of the data that they're getting is biased data.
Right.
And when the data is biased, and I'm not sure if our audience would have heard about stable diffusion model, which is basically a model, a large language model, which takes all the text out there in internet and translates it into images. And what it did, the output it gave was that 100% of the CEOs, or 98% of CEOs of the organization, are white male, women of color like me and you, flip burgers and our dishwasher. So that is what is the bias that exists in artificial intelligence currently right now. And so how can we debias those large language models, because we are using those large language models. And I gave a talk about that in Basel, Switzerland this year. And Johns Hopkins Applied Physics Lab did a work on digital retinal imaging. And what they realized, that digital retinal imaging between African American is different than image of the retina of a Caucasian population. So when they used the standard large language model to detect the diabetic retinopathy, it found that there was, for white Caucasian patients, for detecting at 70% rate, and for African American, it was detecting at 60% rate. So there was a big gap in terms of disease detection for African American population. So they debiased that model and ran it again, which is a long process, but I'm just trying to summarize that.
Yes.
And when they found out that they were able to remove that bias and improve the outcome. So because if the disease is not going to be detected in our diverse population, it means they're not going to have access to ophthalmology. They're going to end up having blindness. And so all those health outcomes are linked with that. So definitely, we need to do a lot of work in artificial intelligence. And, I've given different talks about the guardrails and the safe use of AI, and what is the role of the board in AI governance. So I'll pause there. It was a very long answer.
No, that was great. I mean, I think you definitely took us through kind of multiple iterations and how to think about it, and even kind of going back to thinking about health equity conversations as a system. When we say that the system is always designed to get the outcomes that it produces, right? And so we think about that too in clinical trials and data collection before we even talked about AI, right? So if we don't set up the research project the right way and collect the data from diverse populations, then we're going to get a subset of information that may or may not be usable. And then that translates directly to what you just said about AI, right? If we're not gathering the data in the right way, then we're going to get biased data back out that may exclude populations or decrease diagnosis in certain populations, but it could also be harmful in other ways, right? And even thinking about the imagery about what different populations look like, and I think we just have to be mindful. I think there are clearly lots of applications. There's lots of benefit. There are lots of things that it could be helpful and move things quicker. But if we don't move things quicker in the right way, then of course, to your point, it could be detrimental in the long run. So just being mindful about it on the front end, so we're not trying to your point, since they didn't do it on the front end, no extra work on the back end to go back and correct it. So those are all very, very good points. As we're coming to a close, I usually try to ask a forward-thinking question, which you've given us so much to think about today. I mean, I think because AI is so top of mind right now, what I guess two questions. I'll give you a two-part. what are you hopeful for going forward with digital technology, specifically artificial intelligence? And two, what scares you most about the technology?
Right. That's a great question. I'm very hopeful when it comes to AI and technology, and I think AI is used as a force for good, it can achieve a lot. With the proper education and training of our providers and our workforce, we can use it to improve productivity. We can use it to reduce disparities. We can reduce to do so many things that we were not able to do maybe 5 or 10 years ago. So I am very hopeful, and I'm optimistic when it comes to artificial intelligence. Where I'm concerned is, again, artificial intelligence and the detection and algorithms using against diverse population. And I'll give you an example where I talked about several lawsuits that are coming up the pipeline, and our healthcare industry is sort of delayed in lawsuits, where the other industries have already got their fair share of the lawsuits because of the artificial intelligence discrimination that have been embedded in their software, and some of it by design they have done it. So EEOC has, which is the employment uh, equal opportunity employment organization, settled a lawsuit with iTutor for millions of dollars, where they use a discriminatory software where it excluded applicants of certain age and race and ethnicity. And so that has already been settled, but there are several lawsuits against insurance companies, as you must have heard in the news about United Healthcare, where certain discriminatory softwares were used to deny payments. And there are other lawsuits out there. So that's what scares me. As instead of using as a force of good, it is used against our patients and our members and our workforce, to have only one segment of the population benefit from it. So that's what my concern with artificial intelligence is. And I'm hoping, and the government, White House came out, Biden's administration came out and gave an AI directive last month about the guardrails for AI. And I think each of our organizations have to take a very strict pathway when it comes to AI and what it is used for, and to be transparent, to be open, and not have AI work in a black box, to have all the standards of National Institutes of Science and Technology standards embedded into it. And all that has to be part of the AI governance that we need to use before we develop those systems, whether it be intake systems for our insurance organization, or systems that determine what patients and members are eligible for certain medications. So that's one thing. And there's an organization called CHAI, a coalition of our healthcare AI, which sort of have a several page document regarding AI governance in healthcare specifically. And EU also recently came out with some governance guidelines regarding AI. So I would like our readers to go out and read those, whatever simpler version they can find. And all of our healthcare providers, members, patients need to educate ourselves on what is going on in this space, whether it's our reading or whether it's our work and advisory board role, because that is going to help us understand what is happening around us, but also be a good consumer of artificial intelligence and provider. That's all.
That's perfect. I think that I thank you for bringing it back full circle. It is a force for good that has a lot of applications for a lot of patients to make life better. But we need guardrails. We need to be aware that biases can be there. And if we think about it on the front end by doing our homework, like you just said, and making sure that we are as educated as we can be when we move into a project, that hopefully then we will, it's like anything else, just trying to do our due diligence to serve as many patients and members of our population in the best way possible. And in relation to AI, that just means being very careful on the front end. So thank you for bringing us back around to our optimistic point of the conversation. But But with that, thank you so much for taking time to share a little bit about the many things that you do. A very diverse career in health equity, and I always try to mention that the health equity conversation requires inputs from multiple places, right? And so, you
Hmm.
know,
Yeah.
being a clinician is not always the best way on member to member care to affect health equity, but it's needed, right? Because people still need point of
Yeah.
contact care. But we also need to work on population health interventions. We also need to work on continuing the conversation in the boardroom so that the conversation of health equity is woven into the fabric of the organization going forward. So thank you for doing all of those things, and really looking forward to seeing where the conversation takes us next.
Thank you. Appreciate Mary for inviting me. And I always appreciate all the work that you're doing in this space and looking forward to our future collaboration. And thank you.
Absolutely. Thank you for listening to Reed Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.